Welcome to the educational event entitled Establishing the Collaborative Benchmark for HCC Care, Critical Discussions Between Interventional Radiologists and Oncologists to Maximize Therapeutic Benefit. My name is Riyad Salem, and I'm pleased to be joined by Dr. Mark Yarchoan from Johns Hopkins. Thank you to PeerView and the Society of Interventional Oncology for providing this session, and AstraZeneca for providing the educational grant for this symposium. A reminder to look out for additional follow-up polling during the presentation. Also, please submit your questions in the chat box, and we will answer them via the live chat feature during the program. Please also visit us at peerview.com, HCC Virtual 24. You can view the slides and have practice aids now and download them after the event. I'd also like to thank the Society of Interventional Oncology and remind everyone and highlight the fact that there are many symposia that SIO is offering. You can see here the topics that are going to be covered during these symposia, and these resources and other practice tools are available as downloadable resources. The goals for today are about improving your understanding of the pharmacological rationale and latest safety and efficacy evidence for immune-based strategies for early, intermediate, and advanced stage HCC, to enhance your skills to integrate team-based strategies to select immunotherapy options for intermediate and advanced stage HCC, to equip you with tools to address practical aspects of care when integrating immune checkpoint inhibitors and local regional therapy-based treatment for HCC, including adverse event management. Again, my name is Riyad Salem. I'm Chief of Interventional Radiology at Northwestern, and I will be starting this seminar. One of the things we need to recognize is that HCC mortality in the United States is increasing for both men and women, and that HCC is one of the top drivers of cancer deaths in the United States. HCC mortality is also increasing globally, with over 1 million people that were diagnosed with liver cancer in 2020. Over 800,000 people died from liver cancer in 2020, and that the number of people diagnosed or dying from liver cancer globally is expected to increase by over 50% in the next 20 to 30 years. One of the things that we need to recognize in managing HCC is that really the modern approach for HCC care is multidisciplinary, it is dynamic, and intensely collaborative. Patients will really shuffle from treatment to treatment depending on their tumor presentation, their response, their outcomes, and really will be managed by multiple subspecialties that include radiology and other treatments like those offered by medical oncology and radiation therapy, etc. And so really patients will shuffle from treatment to treatment as they navigate through the management of their HCC. There also needs to be a recognition that there's tremendous advancements now in characterizing HCC in the cirrhotic liver, and the modified BCLC staging system really does this very well, where by using tumor burden, performance status, and liver function, you're really able to subdivide patients into multiple stages that are really readily understandable and translatable from clinic to clinic and practitioner to practitioner, that really then allow us to take that stage and consider the best possible treatment option for that patient based on clinical experience and levels of evidence. We also know that basically patients that are treated by all subspecialties in the multidisciplinary team approach do better, and their survival outcome is improved. You can see here that there's really a benefit of having patients to be seen by medical oncology and hepatology and interventional radiology and surgery, so that the best treatment approach can be applied to that patient at the best time. And again, several papers now have shown that the survival outcome will improve when these types of approaches are undertaken. Let's now talk about the power of partnership for HCC and really the team-centered strategy for optimizing immunotherapy and local regional therapy options in earlier stages of disease. So I want to start with a case, a patient with BCLC B-HCC with good liver function, good performance status, has unilobar multifocal disease without macrovascular invasion. And so the idea here is, what effective treatment approach would we consider for this patient? So let's take a look a little bit at the evidence. So first, there is clearly a rationale for combining local regional therapy and systemic therapy. The first thing I would say is, In BCLC-B, it is well recognized that it is a heterogeneous entity with variability in tumor burden and underlying liver function, and that the ability of a local therapy to affect response and benefit the patient will be affected by the magnitude of tumor burden. We also need to ensure that we do not miss the opportunity in the window to transfer the patient from local regional therapy to systemic therapy because of too aggressive liver therapies that may cause liver function deterioration. And of course, systemic therapy has significantly moved the field forward with level 1 evidence, with improved survival and high response rates. So the idea here about combining these two types of approaches are things about starting effective therapies earlier, like systemic therapies, when local regional therapies have been maximized, introducing more effective interventions before the idea of liver decompensation, and increasing the possibility of cures, something we all seek for our patients. The other thing that I think is important to recognize when you think about the spectrum of disease and the treatment that usually dominates that landscape is usually in earlier disease, as you go from earlier to more advanced disease, the local regional therapy dominates early, and then as things get more advanced, that gets converted to systemic therapy based on practice, based on level of evidence. And now we're seeing with all of these treatment options that are available, more of an overlap between these types of treatments. And that's really the theme of tonight and the theme of what we're trying to talk about today. Now, when you think about local regional therapies and when to consider applying, for example, chemoembolization, there are various models that have been developed on who is an ideal candidate for chemoembolization, what sorts of prognostic factors are they, can we predict overall survival based on some scores, and there is a linear predictor score that's been published here, the 6 and the 12, that depending on the score that you have, you're able to prognosticate overall survival. So there clearly is some work here to think about, well, will this patient benefit from a local regional therapy? Should we think about a systemic therapy earlier? But these types of tools are extremely important as we try to manage the patient in that landscape of local regional therapy and available systemic therapies. The other challenge that really exists is when you think about assessing response to chemoembolization. This is a diagram that was published by Kudo and others that really look at the spectrum of how patients present with liver cancer. And you can see that when you have a few lesions, assessing response might be relatively straightforward. But once you have a much more heterogeneous presentation, large tumors, smaller tumors, it's very difficult to assess response. And one might postulate, and I would agree, that when you have more disease burden, the likelihood to response to taste and the ability to treat the entire disease becomes limited. So we have to recognize that in reality, the heterogeneity that we see here suggests that there's a need for a shift in paradigm when we think about BCLC-B patients, particularly those that have more advanced local liver disease and more tumor burden, because we have to think about preserving liver function and letting the patient benefit from systemic therapies that improve patient outcomes and overall survival. Now, there are some exciting data that have emerged and other studies that are ongoing. First and foremost is the Emerald-1 study, which is a phase 3 study looking at the effect of Durva-Bev combined with chemoembolization in patients with sort of liver localized HCC. All arms had chemoembolization. One arm had Durva alone, one had Durva-Bev, and one had chemoembolization alone, with the stratification factors that you see here on the modality, on the geography, and on the presence of vascular invasion. One of the interesting things about this study schema, which I think is different than others, is the local regional therapy was started first. Durvalumab was given with all of the arms, as you can see here, except the placebo. But everybody was able to get the necessary chemoembolization to treat all of the disease. And the Avastin effectively started around month 6 or month 4, and then the responses were assessed around month 6. But basically, it really mimicked clinical pattern and clinical practice, which is perform the local regional therapy, add the durvalumab when in the right arm, and then add the bevacizumab at the right time. The other interesting thing about the data that emerged from Emerald-1 is the fact that effectively most patients will receive 1 or 2 chemoembolizations in their lifetime. And I think that's important to recognize because anything more than that really results in the patient incurring added risk of liver function decompensation and potentially preventing that patient from benefiting from systemic therapy. So really 1 or 2 and sometimes 3 embolizations is what you want to be thinking about, at which time transitioning to systemic therapy is really becoming the standard of care. The results were described and presented at ASCO GI in 2024. And you can see here that there was a significant PFS benefit when you had Durva and Bev and chemoembolization versus chemoembolization alone, almost a doubling of PFS. And you can clearly see here that the effect is at around 6 months after the bevacizumab has been added. But really sort of the first positive study that really puts these two treatments together and imparts a clinically relevant outcome for that patient in the almost doubling of median PFS. That difference was not seen between the Durva-TACE and placebo plus TACE arms, suggesting again that the VEGF targeting may provide some type of boosting effect. Adverse events are what you might expect. This was the initial presentation where you might see the expected adverse events of hypertension, of proteinuria, a little bit of encephalopathy, some ascites, and some bleeding. Much more detail will be presented at ASCO 2024 by Stephen Chan as an abstract, as you can see here, that will be shown at that meeting. Now, I'd like to bring in Mark here and really talk about this case now that we've sort of set the stage for what exists and where we are with the current landscape. Mark, if I could have you sort of give me your thoughts on this patient. If you saw him at Hopkins, good liver function, good performance status, sort of a textbook BCLC-B, maybe more burden than we're comfortable with. But do you think TACE alone is the best option for this patient? Do you think the Emerald-1 is something that you've incorporated already? And again, and the last thing would be, what if you had a little bit of vascular invasion? Would that change your thinking?
Yeah, I think this is a great case because I think this patient could be presented at multiple MDCs and come out with different recommendations, even at very good places. Because I think even as someone who's familiar with all the published data, I think there's still controversy about what to do with a patient like this. This is someone who, again, I'm not an interventional radiologist, but looking at the scan here, the disease is really confined to the right side. I don't think the right side of the liver is contributing to hepatic function in a meaningful way because it's all tumor. So, what we worry about with repeated local regional procedures is the detriment to the healthy liver. And I think in this case, that's really not a concern. So I actually think this is a great case for local regional therapy. And even though traditionally we think about local regional therapy in cases without portal vein thrombosis, which technically pushes people into the advanced stage setting, even that has become a bit of a moving target. And I don't think it would change the way I would think about this case if it were just a small PVT. So I actually am very much in favor of a local regional therapy first approach here. I think the more complicated question within your question is there a role for systemic therapy also? And if so, how is that introduced? So maybe I'll just turn it back to you since I answered the interventional radiology part. Do you see a role for systemic therapy here?
Yeah, that's a great question. So, yeah, I would say, I appreciate the response. I do think that you're absolutely right. When we think about what we're going to do with patients like this, clearly he has a lot of normal liver on the left-hand side. It's hypertrophied already naturally. So that's where all the synthetic function is coming from. So I don't think it's unreasonable to think about a local regional therapy first because there's going to be a lot of liver that's spared. Now, obviously, when this becomes bilobar, it's a little bit different. We can talk about that later on. But I don't think it's unreasonable to think about that. And certainly I have become a fan based on what I'm going to talk about a little bit later on is the safety profile between LRTs and sort of immune checkpoint inhibition, I think has been pretty well accepted now in sort of some perspective, some retrospective studies. It's not unreasonable to think about adding a systemic therapy, maybe even earlier than waiting for progression. I think that's a topic that'll come up a little bit later on. So I think we may have some consensus here to start with an LRT, to watch this patient carefully, and to be ready to implement systemic therapy maybe a little bit even earlier than what we might have done traditionally. Would you agree with that?
I would. I mean, I think you showed the Emerald One data showing, an advantage from the progression standpoint. The big debate right now is progression really a clinically meaningful endpoint? And what we really want to see is we want to see this translate into overall survival benefit. And so I think the question is, if we introduce systemic therapy earlier, as I think has happened naturally even without Emerald One, are we really bending the the long-term trajectory of the disease? Is it really truly disease modifying? And I don't think the jury is completely out yet. But this is a case where there's enough disease. It's very borderline whether you would do systemic therapy or local regional therapy. And I think this is the sort of case where there may be a role for both, and it's certainly something we would talk about.
Yeah, I think we have agreement. So for the audience members, please take a look on your screen and answer this question before we move on. Take a look at this to answer the two follow-up polls on intermediate stage HCC. The other thing that I want to talk about is really sort of the emerging data or things that we are waiting for. So there's the Emerald 3 study looking at durva with an anti-CTLA-4 and a TK plus or minus a TKI in combination with chemoembolization. So there's a lot of interest in this space where one group, of course, will have the chemoembolization alone. You'll have the durva-tremi in one, and then durva-tremi plus a TKI len. And so there's a lot of studies that are really looking at this patient population to see what combination they might benefit from. The DEMAND trial is going to assess atezo-bev with or without chemoembolization in intermediate HCC. So you can see here even the IMBRAVE mechanism. That approach is going to be evaluated in this patient population with or without chemoembolization. There's the LEAP-012 study, which is a phase 3 trial looking at len-pem with chemoembolization. So again, both groups will have TACE, and one group will get len-pem in a randomized setting. So a lot of interesting data that hopefully will come out of this trial as well. And even now, there are prospective phase 2 studies looking at the role of yttrium, of radioembolization, in a prospective manner, combining one in the Emerald Y90 study, durva-bev after radioembolization, so the same format that you saw in Emerald 1, which is do the LRT first and then implant the systemic therapy, and the Rowan trial that's going to look at durva-tremi also after radioembolization. So a lot of interest in that space as well. Certainly a lot of the traditional chemoembolizations, which is the global gold standard, is being replaced by yttrium, at least in the United States. There's also the SOLID trial that was published last year, again, looking at Y90 plus durva for locally advanced disease. Now that always the devil's in the details is what's locally advanced disease. But median TTPs of 15 months or so, and survival not really reported. But again, just showing that you can do these types of therapies together, and there are no signals from an adverse event profile from a safety standpoint. There was a very interesting study just published in the Oncologist a couple of months ago on PEM plus Y90 in patients with poor prognosis, so they had PVT or multifocal disease, et cetera. So interesting survival there, report of 27 months. So interesting to see more of these types of outcomes come in, but interesting data of Y90 plus PEM. I think the first one that came out that sort of gave us a signal was Bruno Sangro's group looking at Nivo after CERT in a subset of BCLC B patient population, again showing that the response rates were in the 40+%, the survival was in 20+ months, but again showing that you can do these types of treatment safely. That I think is permitting clinicians like myself and Mark to really practice and apply these types of treatments in combination or in sequence, depending on the timing. There are also other trials that are ongoing that really look at the role of immunotherapy with LRT. We know that there's data on ipi-nivo, durva-tremi, cabozantinib, of course, and the atezo-bev format. So a lot of studies that we're waiting on to see what types of outcomes we're going to see. So when you think about sort of from an interventional radiology perspective and the oncology perspective, joining forces, working together, for me, I think there clearly is a rationale to combine these types of therapies, and that rationale is continuing to expand. In the real world settings, these combinations have been proven to be at least safe with outcomes that are thought provoking. I just showed you that PEM data with the Y90. And I think the IR oncology collaboration really spans the entire BCLC spectrum. It used to be less involvement on the BCLC A and B side from medical oncology, but clearly now we need our oncology colleagues to help us in those stages as well. And that includes, of course, initial diagnosis, biopsy or repeat biopsy, of course, treatment and assessment of response. I'd like to invite Mark now to talk about other types of developments.
And I'm Mark Yarchoan. I'm a medical oncologist at Johns Hopkins in Baltimore, Maryland, and I'll be addressing the early stage HCC section here. So as always, we start with a case. We have Barbara here, who's a 58-year-old female with a solitary HCC in the right lobe that you can see on the scan here. Well-preserved liver function, Child-Pugh, good performance status, and an AFP of around 5,000 prior to surgery. So I'll ask our audience, how would you treat this patient, and would you see some role for either neoadjuvant or adjuvant systemic therapy or other therapies? And we'll come back to this case in this section, but right now we'll turn to the evidence. So as probably everyone here knows, HCCs are generally considered to be a reasonably immune suppressed tumor. Most HCCs have relatively low tumor mutation burdens, relatively low levels of PD-L1 expression, and relatively low CD8 infiltration compared to other tumors. And I think ongoing subtyping of HCC is an evolving space, but as you can see here, some prior efforts have attempted to divide HCCs into more immune exhausted, excluded, or infiltrated subsets. But these sorts of biomarkers are not currently used in clinical practice. We really have no effective biomarkers to decide which HCCs are amenable to systemic therapy with immunotherapy. In terms of hepatic resection remains the preferred treatment for any potentially resectable HCC. So just going back to the first case, that case is considered resectable because any HCC that's a solitary lesion in a liver that can tolerate resection is potentially a resection candidate. And again, there have been other attempts to decide which tumors are more favorable for resection or less favorable. But I think in this case, the solitary lesion and the fact that it's a preserved liver make resection an ideal treatment. I think the one thing arguing against resection is actually the AFP of over 5,000, which is definitely a poor prognostic feature and biologically makes you even more concerned about recurrence. And of course, recurrence is a risk for any HCC that is resected. So there have been data that recurrence occurs in over 70% of resected HCCs. Obviously, tumor size is a risk factor. AFP, as we discussed previously, any sort of vascular invasion is considered a major risk factor for recurrence. And I want to fast forward to the IMbrave 50 study. So obviously, when we have such a high risk of recurrence, immediately all of us should think about ways to reduce the risk of recurrence. And unfortunately, until very recently, we really had no systemic therapy that ever showed a benefit in the neoadjuvant or adjuvant setting in a large phase 3 trial. But that changed with the IMbrave 50 study. So this was a study that took patients with resected or ablated HCC, although really this was a resection trial. The majority of patients were resected, and they were randomized to active surveillance, which of course is the standard of care, versus adjuvant atezo-bev for a year. The tumors included in this trial were specifically high-risk tumors, so large tumors over 5 centimeters, multifocal disease, tumors with vascular invasion, or poorly differentiated tumors. Interestingly, AFP was not a criteria for this trial. It was not routinely checked. And this is the overall early data that was presented at AACR in 2023. And what you can see is that the trial hit its primary endpoint. So recurrence-free survival was improved with adjuvant atezo-bev. However, this regimen has not been included as a standard of care, at least yet. So this is not yet FDA approved. And I think the reason for that is that even though you see some early separation of the curves, this is really early data. And what we don't know yet is, will this early separation of the curves translate into long-term separation of the curves, or even better, a long-term survival benefit? So we don't really know if we just made the scans better, or have we really changed the long-term trajectory of the disease? And I think that answer has not quite been figured out. So, for the case that was presented at the beginning, we have the solitary large lesion with an AFP of 5,000. Obviously, the risk of recurrence is over 80% if you look at the data in a tumor like that. So this is the patient where I would at least discuss adjuvant atezo-bev with the patient. I wouldn't necessarily say that this patient has to do it. I don't think the data is strong enough, but it's at least something that I would talk to the patient about. And it was just added to the NCCN this month as a potential option, even though the panel did not feel that the level of data was strong enough to routinely recommend it. So again, will we improve long-term survival? I think we don't know. Obviously, we hope that that early separation of the curves translates into a long-term separation. And at least right now, the fact that the curves come together is quite disappointing. And I think, obviously, long-term follow-up is really going to help us. At least right now, at this very early time point, there were actually more deaths in the intervention arm than the control arm. And there were some treatment-related deaths. So obviously, we're all comfortable with atezo-bev in the advanced setting, but there is something particularly challenging about losing a patient to an adjuvant regimen who might have been cured with surgery alone. And so I think that's why, until we have longer-term data, it's something that I think we definitely talk to our patients about this, but it doesn't mean that we need to use this routinely in every patient. And with the case that we presented at the beginning with the AFP of 5,000, I might be more interested in offering this to my patient if the AFP didn't normalize after surgery, where the chance of recurrence would be even higher than if the AFP normalizes. So something that you can consider on a case-by-case basis. I do want to just quickly talk about other adjuvant studies. Atezo-bev was really the first large randomized study, phase 3 study of immunotherapy for resected HCC. We have a number of other studies, and these studies will more clearly determine if we really need the bevacizumab or whether immunotherapy alone is enough to confer a relapse-free survival benefit. There was a smaller randomized phase 2 study from Asia that suggested that PD-1 alone might be enough to prevent recurrence. And so I think we'll know much better whether we need the bevacizumab, because some of these trials do not include Bev, and particularly the Emerald 2 study is durvalumab with or without Bev. So we'll know the separation of components there. So now we return to the case that started the segment. So why don't I bring in Riyad for a moment? So Riyad, going back to this case, anything that you want to add, and how would you approach a case like this if it came through multidisciplinary clinic?
Yeah, I think we think alike quite a bit on this case, Mark. This is a non-cirrhotic, and again, I like to look at sort of the tumor burden, as I mentioned before. He's got good liver function. He has very large left lobe, so right away you're thinking in a non-cirrhotic. Resection is the gold standard if resectable up front. There's a bad prognosticator, of course, with the elevated AFP, as you mentioned. But clearly, I think about resection. One of the things that we are doing in some settings, depending on the patient population and the size of that left lobe, is to actually perform a local regional therapy as a test of time and to even hypertrophy that left side. Some people might think about portal vein embolization in that setting, but in a tumor this large, Mark, the portal vein is already compressed, so you really can't embolize an already compressed vessel. So you might think about something called a radiation lobectomy or another technique. But basically, I'm in agreement. You want to resect this thing as quickly as possible, and then have that discussion about whether adjuvant therapy is indicated.
Yeah, I think that's an important point is, what do you do if the liver reserve is questionable here? And I think, it's great to think about ways to hypertrophy the left side, because this patient's going to need, obviously, large resection, lose the entire right side there.
That's right. That's right. If I can just add, based on this image, Mark, it might even be. I mean, they'll try a right hepatectomy, but the middle hepatic vein is very close by. It might even be a right triseg, and so they will lose everything except segment 2, 3. So you're absolutely right. We got to make sure that there's enough liver preserved.
One of the things that we certainly debate, and at least, HCC circles is there a role for neoadjuvant immunotherapy, which is a evolving paradigm. I think there have been a number of smaller phase 2 studies showing at least safety and feasibility of neoadjuvant immunotherapy with fairly impressive long-term clinical follow-up, but I don't think that this is ready to be instituted as sort of a standard of care. It's something that should, at least right now, be done more in a clinical trial setting. Although, if this patient were to, let's say, get a PVE and need a little time for that left lobe to grow, I don't think it would be wrong to at least discuss immunotherapy as somewhat of a bridge to surgery. I don't know what your thoughts are about that.
Yeah, I think so. I think that field is clearly evolving. And again, some of the regimens, we're clearly seeing that they are safe and patients are tolerating them. So this is all about sort of new ways of thinking, out of the box thinking, and making sure that you use all the proper tools for that patient in the proper scenario.
So if this patient came to my clinic, um, underwent resection, and then came back to discuss the use of adjuvant therapy, I think it would be a discussion in my clinic. And I'm not sure that I'm certainly not routinely offering adjuvant therapy, but I do offer it to select patients. And this patient's high enough risk that it's something I would discuss. I'm curious, I know it's probably the medical oncologists who work with you would be discussing it, but any sense of if this patient would be offered adjuvant Tezobev in your center?
I think it's very much as you mentioned. It's really something that would come down to physician-patient discussion. I don't know that it's been routinely adopted as you're mentioning. We're waiting for the OS, that more mature OS data for sure. So it'd be something that would be discussed, but certainly it hasn't been routinely adopted.
Um, so before we move on, please take a moment to answer a follow-up poll assessing your knowledge of the ongoing trials and recent evidence. So in our next section, we'll be redefining coordinating care for advanced HCC and discussing the transition to systemic therapy. So I want to start out once again with a case. So we have here a 66-year-old male with multifocal HCC who's had 2 prior TACEs and now has developed progression. And as you can see in the CT scan, there's really multifocal, somewhat infiltrative disease, it looks like on the scan. Um, the patient still has preserved liver function and really has no macrovascular invasion. And so I guess the question for our audience is, would you consider this patient to be TACE refractory, or would you continue to TACE this patient? And what is the role for local regional therapy here versus systemic therapy? So let's take a moment and review the evidence. So Riyad covered the slide earlier, but I think this is a good time to circle back to this slide. This patient here, in my opinion, has several reasons to think that systemic therapy is the appropriate next step, and I assume Riyad would agree with me. Not only has this patient already had 2 prior TACEs, and we know that as we continue to TACE the liver, there is a decline in liver function that can impair patient's ability to receive systemic therapy down the road. But also, this is a patient who has, looks like not only infiltrative disease, but really truly multifocal disease. And we know that as you have more lesions, the benefit from TACE goes down, and also the risk of TACE goes up. So this is a patient where I think many of us would favor moving to systemic therapy. There have been different guidelines proposed about when should systemic therapy be favored over TACE. I think one criteria that is somewhat widely used around many parts of the world is the up to 7 criteria, which is really the sum of the largest lesion with the number of lesions. And clearly by these criteria, this patient is beyond up to 7 because there's more than 7 lesions. And so I think this is unambiguous. I don't think that the up to 7 criteria is the end all be all. I think we certainly do local regional therapy outside of this range. And also when patients are within up to 7 criteria, if biologically there are more lesions appearing rapidly, in my opinion, there may be a role for systemic therapy earlier. But I'll turn it over to my colleague here to comment. How do you feel about these criteria, Riyad?
Yeah, Mark, I appreciate that. I obviously philosophically agree with what you said. The patient sort of has progressed already. And I would agree that the more burden there is, the more the reality is your local regional therapy is going to have a limited role and in the presence of good liver function, really needs to be, transitioned over to systemic therapy. Where I would potentially differ a little bit with some people that have adopted up to 7 is, there are some scenarios that are just outside the up to 7 criteria that are really resectable, they're embolizable, they can do all sorts of local regional therapies. So it's like you said, they're not necessarily hard and fast rules. They're a concept that in the higher the burden, the more the disease, there probably should be a consideration of earlier adoption of systemic therapy that I would agree with. And so I think there's sort of this spectrum because like you said, if patient has biologically more active disease and new lesions are popping up, you could still be within the up to 7, but of course biologically need something systemic. So I think it's good to know about these criteria and know about the broad concepts about the more the burden in the presence of good liver function, probably systemic therapy should be the first choice.
And just to circle back to something that was covered earlier in the program, I do think as we move systemic therapy earlier, particularly for patients with larger disease burdens, um, I don't think that the role for interventional radiology completely goes away. And more, we're referring patients for local regional approaches in the setting of oligoprogression, which I think is a totally new concept. So, I think that, again, even patients with more advanced stages of disease often benefit from coming through a multidisciplinary group when it's possible to do so. So let's keep going. I do want to just mention that this has been a very exciting period of time to be treating HCC. I came out of my training really fortunately just when immunotherapy came on the scene for liver cancer, and it's been fun to just see how many new approvals we have. At first, nivolumab and pembrolizumab were approved as single agents in second-line HCC based on really single-arm phase 2 data, and since then, we've had immunotherapy move into various combinations in the frontline setting, starting with the Atezo-Bev in 2020. And actually, we're awaiting 2 potential approvals. One is the combination of camrelizumab and rivasarinib, which is a tyrosine kinase inhibitor PD-1 combination based on a global phase 3 study, the CARES 310 study. And then most recently, there was a press release that nivolumab and ipilimumab hit the primary endpoint of overall survival in the frontline setting, and those data are eagerly awaited. So it's very possible that in the near future we'll have at least 4 frontline approvals to choose from, which would be fantastic. So this is just some top-line data here for immunotherapy in the frontline setting, and Atezo-Bev came first. It was really the first study to show an overall survival benefit over our old standard of care, sorafenib. Since then, we had a pure CTLA-4 plus PD-L1 regimen. That's the Himalaya study with the STRIDE regimen, which is durvalumab plus tremelimumab. Again, I think it's important not to directly compare these numbers because these studies were conducted in different parts of the world at different centers. But I do think that we can draw sort of broad trends here from the data. And I think when you combine a VEGF plus PD-L1 agent, I think the benefit of this is that probably more patients derive some degree of disease control because you're combining different forms of therapy. And so that study really did prolong progression-free survival. I think when you look at the STRIDE regimen, the argument in favor of the CTLA-4 is really that tail of the curve where there's a small group of patients who really do fantastically well, and the responses do tend to be very durable to this regimen, even if it is a smaller group of patients who responded. And then most recently, we have the camrelizumab rivasarinib study. On paper, this is actually the longest overall survival we've seen in this kind of combination frontline positive study. But I do want to just caution that this study was conducted mostly in Asia, predominantly in a Hep B population. So how applicable this is to a Western population is a matter of some continued debate. So next slide. So how do we analyze this data? So I hinted at this earlier. Atezo-Bev was the first regimen approved. It still is, of the approved regimens, the one with the best hazard ratio for overall survival and the only one to prolong progression-free survival. I think what we like about the Himalaya study is that they actually followed patients for 5 years. We just don't have 5-year data for Atezo-Bev. But what you see is on the tail of the curve, there is some flattening. So the patients who do well with durvatremi continue to do well. About half of the patients who are alive at 4 years got durvatremi and nothing else. Some of them continuing to have CR from their treatment. So we've never seen this before with HCC. We've never talked about 5-year survival, and I think it's just exciting that that's the direction that we're moving. We certainly hope that we'll continue to see this kind of data with future studies. When choosing between regimens, atezo-bev includes bevacizumab, which is an anti-VEGF agent. And so, of course, the major thing that we always think about with anti-VEGF agents is concern for, in particular, both bleeding and clotting. The atezo-bev study, the IMbrave 150 study, did require patients to undergo an endoscopy prior to receiving the therapy. There is some newer data that the patients who really bled with atezo-bev were the patients with a portal vein thrombosis, and those patients were actually excluded from the Himalayas study. There is some thought that perhaps for some patients we can just start them on a beta blocker instead of undergoing an EGD, and I think this is a matter of some continued debate in our community. But I would say that certainly when you think about atezo-bev, patients with recent bleeds, patients at very high risk of bleeding, as well as patients with particular risk for vascular complications, recent MIs, recent strokes, those are probably not patients we want to put on atezo-bev. The durvatremi regimen, what we tend to worry the most about are immune-related adverse events. When you add a CTLA-4 agent, the rate of adverse events does go up as compared to PD-L1 alone with regard to immune-related adverse events, although the rate was somewhat lower than we've seen with sort of higher dose ipilimumab, especially because this was a single dose of CTLA-4 and the effective CTLA-4 dose was somewhat lower. So I do want to just quickly talk about the camrelizumab rivaceranib data. This study came candidly as a bit of a surprise to me and some other people because we had technically negative studies of cabozantinib plus atezolizumab and lenvatinib plus pembrolizumab, at least with regard to overall survival. And then out of basically nowhere, we heard that the camrelizumab rivaceranib study was positive, which is a different TKI PD-1 combination. Did they just get lucky? Did the other studies get unlucky? Or is there something different about the TKI here? It's a very pure VEGF TKI. It doesn't have some of the other targets that we've often talked about as being beneficial, but perhaps in combination with immunotherapy were not helpful. So I don't know why the study was positive, but the hazard ratio is clearly very impressive, 0.62. I think the major question is, will this be FDA approved? At this point, this was a global study, but it is not yet FDA approved. We should hear very, very soon whether the FDA will approve this or not. The study was predominantly done in Asia, and approximately 80% of the patients on this regimen had hepatitis B-associated HCC, where we know that the risk of liver decompensation is somewhat lower than some of our patients that we see, at least where I practice here in Baltimore, Maryland. So more to come with this regimen. And then I do want to just quickly talk about the Checkmate 9DW study, which is a randomized study of nivolumab plus ipilimumab versus TKI therapy. This was a global phase 3 study that was eagerly awaited. As we know, nivolumab alone was not quite enough to beat sorafenib in a prior study, the 459 study. And now we have a follow-on study with nivo plus ipi. And by press release, the study is actually positive, which is very exciting, obviously. This is a very high dose of anti-CTLA-4. So it's the ipilimumab 3, nivolumab 1 regimen that's used in other tumor types like melanoma. We eagerly await the data, and it's exciting to know that this is likely to become another option for our patients. Comparing it to the durvatremi data, it's going to be interesting to see. Effectively, we think this is probably a higher dose of CTLA-4, and based on the phase 2 data, the immune-related adverse events rates were certainly higher than we saw with STRIDE. Will this be reproduced in the frontline setting, and will this translate into even though more toxicity maybe, higher response rates and maybe longer term benefit. We just don't know, but eagerly awaited data. I do want to just call everyone's attention to a couple of other exciting abstracts that will be presented at ASCO this year, including new information about prognostic biomarkers for immunotherapy and HCC, as well as some new immune data from my friend and colleague, Dr. Katie Kelly, as well as perhaps um, most excitingly, the phase 3 update from the camrelizumab plus ribociclib data that I showed previously with some longer overall survival data. Look to see that those curves continue to stay separated, which would be very exciting. So how do I finish this segment? I would say this is a very exciting time to be treating HCC. When I started, we just had sorafenib, and I think everyone here who's treated sorafenib knows we were all very eager for some other options. Now, really, you need a reason not to give immunotherapy to a patient with advanced HCC. Patients, when possible, should receive an immunotherapy doublet regimen. These regimens have all demonstrated better overall survival than sorafenib or lenvatinib based therapy. Obviously, at the time that I'm giving this presentation, atezo-bev and durvalumab are the two preferred frontline regimens for HCC. We look in the near future to potentially have some other options here. So circling back to this case, what would push me to treat this patient with immunotherapy doublet? Well, we want to give the patient the longest shot at overall survival. In this particular case, what regimen would I use? I think both durvalumab and atezo-bev are very reasonable frontline options for a patient like this who's progressing on TACE therapy with multifocal disease. In this particular case, if I really had to choose one regimen or the other, and the patient had preserved liver function without contraindications to either regimen, I think in this particular case, I might lean more towards atezo-bev just personally because this patient has a lot of disease, and I think they're likely to only, unfortunately, have one shot at systemic therapy. Just given the amount of disease, the infiltration, it really looks like impending hepatic failure just from the way that the scan is looking to me. So I might lean a little bit more towards atezo-bev, but I actually think that either regimen is totally appropriate, and many of my colleagues might lean for durvalumab, and that would also be an appropriate answer here. I think what's key is that this patient really does still have preserved liver function. If the patient were in a Child-Pugh B sort of range, that might push me a little bit away from bevacizumab and towards a pure immunotherapy regimen where we worry a little bit about bleeding in patients with less preserved liver function. But again, there's no single right answer. Obviously, these regimens are both reasonable and have not been compared head to head. So before we move on, please take a moment to answer 2 follow-up polls on immunotherapy in the advanced setting, and I will now turn it over to Riyad.
Thanks, Mark. I appreciate that discussion. Really a lot of exciting things that are going on, certainly in this space. So as we start to conclude, let's start to think about sort of what the current status and future directions for combining LRT and systemic therapy are for advanced stage HCC. The first thing I really want to spend a few minutes on is something you alluded to earlier, Mark, which has to do with progression. And while potentially mathematically and by using algorithms like RECIST, a PD is a PD is a PD, that's not necessarily the case. And I think one of the things that we need to think about as we evolve in managing HCC is, well, what does the progression look like? Is this broad, diffuse, whole body metastases to the lungs, to lymph nodes, etc.? Or is it, for example, a more localized progression, a new nodule that might be ablated, a new nodule that occurs a year later that maybe biologically isn't as bad as something that occurs very quickly, that might be resected, that might be embolized, that might be radioembolized. So I think it's very important to think about when you think about progression, what is that pattern of progression? And I would say that that pattern of progression now needs to be a variable added to the discussion of the multidisciplinary tumor board. Yes, this person's progressed, but what needs to be done? The other interesting thing, Mark, is you alluded to it, which is what about the patient that's doing well on their systemic therapy, but maybe there's one small lesion that's demonstrating breakthrough, but all other lesions are stable. We are now thinking, we are now implementing a new way of thinking, which is, well, because we're demonstrating safety of systemic therapy and local therapy, how about we keep them on the systemic therapy and we apply a local therapy like an ablation or an embolization and have the patient benefit from both treatment modalities. So this is clearly something that stems from the safety profile we're seeing from the combination, and thinking sort of a little bit in the reverse, which is the patient's doing very well on systemic therapy, and I don't know why this one small tumor genetically has sort of gone through the systemic therapy and is able to break through that. But can we ablate that? Can we embolize that? Can we resect it? It really forces us to think a little bit differently. The other interesting thing that I think is important in future directions is based on liver-directed liver-directed and systemic therapies in the advanced setting, is thinking about how we choose one or the other. As I mentioned before, at some point in the patient's life, both are going to be needed, and it's a matter of timing. But think about that tumor burden that we were talking about, the up to 7 criteria, the diffuse, either unilobar or bilobar disease, and the liver function, and the decompensation to Child-Pugh B in some cases. And what therapy might generate the maximum benefit? Mark talked about that in terms of, well, this one might get me a better response. And that's why I would think about this treatment compared to something else. What are the comorbidities that the patient has and their risk factors? And again, you may be able to select based on that approach. And again, shared decision making. Mark mentioned that really in the patient that was thinking about adjuvant treatment. Talk to the patient and see whether that makes sense for that patient. And there are a lot of unmet needs. Other than sort of an alpha fetoprotein, we have very limited biomarkers that we can use in HCC to see how these patients do. And these patients, as I mentioned in my example, will develop acquired resistance to immune checkpoint inhibition. The role of these patients in the Child-Pugh B setting remains to be continues to be controversial, I would say. So it remains to be established. What is the approach to use in that patient population? Some people are comfortable in the B7 patient population, but again, an unmet need when we think about it. And of course, some clinical scores that I mentioned before, like the prognostic linear model that I talked about, the 6 to 12, is something to be thinking about, because again, we have to make sure that we transition the patient properly. So this brings us now to another case, and I think a very interesting case, where we have to think about really combination type treatments and things about concepts about utilizing all the tools in the toolbox. So Margaret is a 66-year-old patient with HBV with a new diagnosis of HCC. She's got good liver functions, performance status is 1. But on CT, there's an 8-centimeter tumor with vascular invasion with PVT, VP3 basically, and a solitary lung metastasis. On EGD, there are grade 1 varices. But Mark, I'd really like to get into a discussion with you now about, we have all these tools now. We have the local therapies, we have the systemic therapies. You have somebody here with effectively liver dominant disease, depending on how you define that, with a very small solitary met. Can I convince you to think maybe about combination type treatment, something systemic and something local regional in the form of cryo or ablation or radiotherapy? But what are you thinking? What's your thinking based on for example, the launch data that also suggests this type of approach?
Yeah, I mean, I think this is a great case because technically this is an advanced stage HCC, but we know that just the way intermediate stage disease is a continuum, advanced stage disease is a continuum. And I think this is a patient who has, again, a relatively small extrahepatic burden of disease. As far as I can tell here, there's a solitary lung met. This patient's probably going to have the most problem as a result of the PVT, right? That's the most kind of life-threatening issue here. So, this is the rare case where I do think that there should at least be a discussion about some role for a local regional approach to address that PVT, whether that's radiation or LRT or TACE plus RT. All these things I think have some rationale. In this particular case, I personally would probably recommend starting with systemic therapy because it's very possible that this patient will be one of the lucky ones where the disease really melts away, and then you sort of retain your local regional therapy in the case of progression, and or come in to deepen the response or sort of consolidate it. But I do think that this is a patient who, at least at our tumor board, there would be strong consideration for adding some local regional approach, either upfront or down the road. What are your
Yeah,
thoughts here?
I would agree with that. Yeah, I would agree with that, Mark. Thanks. I think really this is a case where it puts together everything we've talked about today. What all of our tools from a systemic therapy standpoint, and those that are from a local regional therapy standpoint, and really try to do the best for this patient. And for me, I'm just most comfortable with the safety profile of the combination. So I think with that, really brings in that rationale that you talked about, that you guys would talk about at your tumor board.
Now, let me ask you, if we started with atezo-bev and then there was interest in trying to really address that PBT with something, how do you feel about the combination of LRT with bev on board? How do you sequence things in your tumor board?
Yeah, that's a great question. So most of my experience in the BEV and the LRT space comes from the colorectal space, where patients have been on bevacizumab for a long time, with sort of chronic attenuation and sort of hyperreactive vessels that make sort of my work difficult to catheterize and to get into. I'd be honest with you, I have not seen it in the HCC space. These patients are not on BEV as long, and so I'm actually very comfortable thinking about a local regional therapy with patients on BEV in the HCC setting. This is new for me. This is sort of new information as opposed to what I'm used to seeing in the colorectal space. So I'd be, in fact, quite interested about it. And in this case, probably I would think about radioembolization, given the very sort of the VP3 aspect with the good results that we've seen with PBT in patients with Y90. But I'd be very comfortable now with in patients on bevacizumab. If you think about some take-home messages, the HCC patient journey, as I mentioned before, is dynamic and really spans all specialties. You heard Mark talk about when he finished his training that we really need now all of the subspecialties to help us manage these patients. It really requires a thorough understanding of all treatment options. Mark sounds like an interventional radiologist, and I do my best to sound like a medical oncologist. You really have to understand all of these data to really benefit your patient, and to really contribute to that patient's continuum of care. Combination treatment, again, local regional therapy and systemic therapy is really emerging, and we're seeing much more of the systemic therapy migrate left. And I think we're seeing the local regional therapies migrate to the right. So again, I think that graph will look a little bit differently in a few years. And of course, that multidisciplinary discussion is really where all of these ideas and concepts are exchanged and discussed. Revisiting this slide one last time, the idea here is that by having a multidisciplinary group, multidisciplinary team with all subspecialties, you make the best decision with the best data at the best time for the patient, and overall survival is going to improve. Please visit us at peerview.com, HCC Virtual 24. Complete and submit your post-test and evaluation for credit. Download the slides and practice aids. Watch the replay of this event in the next 24 hours and the online activity in the coming weeks. Thank you for joining us. My name is Riyad Salem. Thank you, Mark, for a very insightful conversation tonight.
And